The topic of lecture is traumatic injuries of oral mucosa. The lecture outlines mechanical trauma, thermal injuries, chemical burning, radiation stomatitis. Oral mucosal lesions are a common occurrence and very often dentists are called upon to treat such patients. Among many causes, trauma is one of the leading for oral diseases. Oral traumatic lesions are diverse in some present as acute lesions, while the majority are chronic lesions. Such lesions may also impair oral functions to a significant extent and also pose some difficulties in arriving at a diagnosis, especially the chronic lesions. However, prompt diagnosis and elimination of the causative factor ensure better treatment. Injury of the oral mucosa could result from physical, chemical, or thermal trauma. Mechanical trauma can be acute and chronic. The presence of traumatic ulcers is a relatively common finding in dental practice. Such lesions arise from trauma related to bite of buccal mucosa, lateral border of the tongue or lip, chewing, or mastication. Traumatic ulcers seen in the mucobuccal folds and gingiva are related to different irritant factors, such as hard foods and inappropriate hard brushing. Traumatic ulcer due to lip biting after inferior dental nerve block is seen on the lower lip. During orthodontic treatment, traumatic ulcers can occur especially on the buccal mucosa due to the irritation of braces or appliance wires. The reasons of acute trauma can be due to accidental mucosal biting. Sharp edges of prosthesis can injure dental mucosa. Sharp objects, especially toothpick, dental burr, or separating disc during finishing and polishing restoration. Sharp or pointed food stuff during orthodontic treatment. Lip biting after injection of local anesthetic solutions. Faulty toothbrushing, and habitual trauma. For example, falling down. This reason is the most common for children. Lip, on this photo you can see lip biting after injection of local anesthetic solution. That's why the patient should be informed not to eat 2 hours after anesthesia until they will renew the sensation in their lips. So this is such warning should be given to every patient who was anesthetized, not to eat during 2 hours. Clinical manifestation of mechanical trauma. Most often damaged mucous membrane of the tongue, lips, cheeks, on the line between the teeth. Main symptoms are such: pain, hematoma, excoriations, erosions, ulcers, intense bleeding in case of injury by sharp instrument. So these photos presents traumatic ulcer that was caused by sharp or puncturing foodstuff, the hard palate, closely to the molar tooth. And this one shows ulceration that develops on the buccal mucosa due to biting, um, accidental biting buccal mucosa. Diagnosis and differential diagnosis of mechanical trauma is done from case history. Clinical presentation of traumatic lesions vary significantly, and most of the occasions, the cause and the effect can be established with thorough history and clinical examination. Although biopsy of such lesions are not required in most of the occasions, but some may warrant histological investigations to exclude conditions which clinically mimic traumatic lesions. Treatment of mechanical ulcerations, mechanical trauma, depends from size and depth of mucosal trauma. In such cases, stitches is necessary in deep wounds. Antiseptic treatment in erosions, hematomas, and small wounds. For example, such antiseptics can be used: potassium permanganate, hydrogen peroxide, furacilin, chlorhexidine solution. Another medicine that is applied, it is keratoplastics. These are used to stimulate epithelialization of oral mucosa. For example, such medicaments can be suggested: sulcoceryl ointment, vitamin A in oil, and proteolytic enzymes that is used for debridement of necrotic biofilm. Examples: trypsin, chymotrypsin enzymes. The next step in our lecture is deals with chronic mechanical trauma. So this is one of the most frequent causes of oral cavity mucous membrane lesion. It is accompanied by infection, mostly occurs in the elderly and senile people. The frequency of accidental biting of oral mucosa increases with age. This is somewhat facilitated by the reduction of the mucous membrane turgor and the bite decrease, the loss of significant number of teeth, zooprotesis, pathological changes in temporomandibular joint, Godon's phenomenon, and inhibition of regeneration processes leads to more severe trauma cause. Chronic trauma of oral mucosa resulting from repeated and persistent mechanical irritative action of an intraoral injury agent has repeatedly been reported to be possibly implicated in the development of oral squamous cell carcinoma. And this is the third most commonly developed cancer in oral cavity, oral squamous cell carcinoma, the third worldwide distributed cancer in oral cavity. Reasons of chronic mechanical trauma. Defective teeth, malpositioned or with sharp or rough surfaces because of decay or fractures, ill-fitting dentures, sharp or rough surfaces, lack of retention, stability over extended flanges, and or parafunctional habits, for example, biting of oral mucosa or sucking, tongue thrusting. So these photos shows chronic biting of the buccal mucosa with diffuse irregular lesions and diffuse irregular white area of lower lip due to accidental and chronic biting of the lip. Actually, not accidental, but chronic biting of the lip. Clinical manifestation of chronic trauma. The clinical cause of chronic ulcers depends on the degree of secondary infection. Old ulcers may become cancerous. And patients can visit dentist with such complaints on burning and tingling, hyperemia as a result of catarrhal inflammation, disturbance of the integrity of the mucous membrane, for example, can be excoriations, erosions, ulcers, proliferative effects such as hypertrophy of the papilla, papillomatosis, hyperkeratotic manifestations as a result of keratinization of surface layers of mucous membrane, leukoplakia. Single or several elements of lesion can be present. Decubitus ulcer or pressure ulcer or bad sores bad ulcers. So, the definition of decubitus ulcer is such. It is focal ischemic necrosis of skin and underlying tissues at sites of constant tissue pressure, recurrent friction, and inadequate perfusion in patients confined to bed or immobilized by illness. Malnutrition worsens the prognosis. The case of decubitus ulcer in the oral mucosa is quite rare in occurrence, and very few cases are reported till date. It considers to be severest outcome of traumatic ulcer. It often presents as a flat or dish-shaped ulceration with distinct margins. Edges of the ulcer are slightly dense due to chronic inflammation. Swelling, hyperemia, and induration are found in the surrounding soft tissues. Bottom of ulcers is often tuberous, covered with necrotic or fibrinous coating. The size is different, small to large. So it is a clinical manifestation, objective manifestation of decubitus ulcer. And here you have the photo of decubitus ulcer or pressure ulcer. Due to the position of a single tooth in the alveolar bone, and this single tooth do actually pressure to mucosa, and in this area there is a pressure ulcer or decubitus ulcer. Defects can occur anywhere in the oral cavity, usually develops on the lateral side of the tongue, on the buccal mucosa, as on this photo, lips or gingiva. It is moderately painful. The surrounding area is usually red and can be covered by a grayish pseudomembrane coating. Patients report severe pain during communication, eating, and regional lymph nodes can be enlarged. This diagram shows stages of pressure source progression. So on the first stage, skin is unbroken but inflamed, skin or mucosa. In these photos, it is skin, but as pressure ulcers is typical for those people who are immobilized. That's why usually it goes about skin. But in oral cavity, it goes about oral mucosa. So skin or oral mucosa is inflamed. On the second stage, skin or oral mucosa is broken to epidermis or dermis. On a third stage, ulcer extends to subcutaneous fat layer. And in the fourth stage, ulcer extends to muscle or bone. And pay attention to edges of the ulcer. It has undermining edges. Diagnosis of decubitus ulcer is done using several diagnostic tests. Here you have this photo, and such imaging technique can be suggested. Magnetic resonance imaging, computed tomography, CT scan, fluorescence imaging, ultrasound imaging, and some others. And of course, microbiological tests, biopsy, blood test. And actually, diagnosis should be done by the analysis of multiple factors, including lesion's location, size, grouping, onset, patient's age, involvement of other systems of the body, and of course, cause of the disease. Histopathology, biopsy of the lesion may be specific, especially in certain potentially fatal diseases. Differential diagnosis of decubitus ulcer is done with other ulcerations that can be present in the oral cavity. And these are tuberculosis ulcer, cancerous ulcer, syphilitic ulcer, and trophic ulcer. So differential diagnosis of decubitus ulcer and tuberculosis ulcer. Primary tuberculosis has deep, irregular, persistent, and painful ulcer on the tongue, with rolled border and yellowish granulation tissue in the bottom. Secondary tuberculosis, chronic ulcer, painful and indurated. In microbiology will be visible giant cells of Langerhans. Cancerous ulcer and decubitus ulcer. What is the difference? First of all, squamous cell carcinoma is the most frequent malignancy of the oral mucosa. In the early stages, white or red-white focal surface lesions are seen, while ulceration with induration and elevated margins is characteristic in later stages. The surface shows a granular and or necrotic appearance with easy bleeding. And here you have this cancerous ulcer, cancer of the red border of the lip. So ulceration of the lower lip with crusting, and it is associated with oral squamous carcinoma, the most typical oral cancer. Differential diagnosis of decubitus ulcer and syphilitic ulcer. So syphilitic ulcer and syphilis in particular, it is highly infective disease. Ulcer is painless, solitary, with indurated margins and ipsilateral lymphadenopathy. Healing of such ulcer within 3 weeks. Hot chancre is characterized by typical dense infiltrate that surrounds it. Ulcer is of an oval or round shape with flat bottom of mid-red color with greasy luster. In microbiology, there is a Treponema pallidum. Trophic ulcer and decubitus ulcer. Usually it is found out from anamnesis that such patient has cardiovascular disease. Those who have trophic ulcer in anamnesis usually will have cardiovascular disease. That's why there is a trophic disturbance, a nutrition disturbance of oral mucosa. So such trophic ulcers develops. Localization of trophic ulcers, usually retromolar area, buccal mucosa, and etc. Different shape and size, covered by fibrinous coating, smells bad, and severe painful. And actually, that is a photo of trophic ulcer of the mucobuccal fold. Such ulcers do not tend to heal without special treatment of systemic disease. So at first necessary to find out reason and provide some management of the reason of the general systemic disease, and only after that there will be healing of oral mucosa. So treatment of ulceration, chronic and acute, and decubitus ulcer. So treatment of mechanical trauma of oral mucosa. The first step to find reason. And after that, eliminate reason. find and eliminate reason, or make it not so aggressive. And of course, after that should be done oral sanitation, professional oral hygiene. And second step, it is symptomatic treatment. Should be done following treatment protocol of ulcerative necrotizing gingivitis or stomatitis. And in the list of the treatment remedies, we have such medicaments. The first one, it is antiseptics, especially drugs that inhibit anaerobic microflora. For example, those that emit oxygen, hydrogen peroxide, potassium permanganate, chlorhexidine. Brand name of chlorhexidine solution that can be used, Perio 8. Such ulcerations are usually painful, so topical anesthetics is of great importance. They can be they are available in the formulations of gel or spray. Active ingredient of topical anesthetics can be lignocaine, trimecaine, mepivacaine, benzocaine. That's why in the cases of severe pain, analgesics are prescribed. But as I said before, any ulceration in oral cavity impair communication, eating, articulation. That's why it is necessary to provide topical anesthesia of such lesions to make comfort to the oral cavity, to make comfort to the patient. And after the lesion was anesthetized, should be done careful debridement. Removal of necrotic tissues from the surface of ulcers is done with proteolytic enzymes such as trypsin, chymotrypsin. Similar but less effective influence on necrotic tissue is exerted by 0.25% solution of soda and hydrogen peroxide. If necessary, should be prescribed antibacterial therapy topically, taking into account sensitivity of the microflora. It can be Metrogyl Denta gel, an example. Anti-inflammatory medications. Non-steroid anti-inflammatory drugs such as nimesulide, proteolysis inhibitors can be suggested to the patient. Anticoagulants, heparin, fibrinolizin, antiplatelet agents is indicated for the regulation of microhemocirculation disorders. And final option for treatment, it is medicaments that is responsible for stimulation of reparative processes. These drugs enhance phagocytosis, such as lysozyme, pyrimidine-based drugs, methyluracil, pentoxyl, vitamins, especially ascorbic acid or halascorbine, vitamin P. Such ointment as sulcoceril improves regeneration of oral mucosa. Herbal remedies is applied in the form of mouthwashes to stimulate reparative processes such as chamomile, eucalypt. Rinsing with artificial lysozyme as well will be very effective because this medicament stimulate local immune system of oral cavity. Thus, all reparative processes will go faster. And this photo shows you this simplest example of medicaments that was in the previous list, just for you to look at them and memorize and keep in your mind this at least one example from each group of medicament. This is antiseptics with chlorhexidine perioate. The active ingredient is chlorhexidine. Topical anesthesia in spray, lidocaine, as well topical anesthesia is available in gel, benzocaine. Proteolytic enzymes for debridement, artificial lysozyme to improve local immune system, such medicament as Lizobact, antibacterial medicaments, Metrogyl Denta, medicaments that is used for stimulation of reparative processes, methyluracil ointment, sulcoceryl ointment, keratoplastics, uh, it can be different white oiled vitamins. Here it is a photo of carotolin. It is rose hip oil plus sea buckthorn oil, so different oils in combination. And of course, if it goes about some burning injuries or any lesions on the oral cavity with panthenol component, these lesions will cure faster because panthenol is responsible for skin regeneration. We have successfully finished with mechanical trauma, and next step in this lecture is physical trauma. So physical trauma of the oral mucous membrane is caused by factors which include the effect of high and low temperatures, effect of electric current, and radiation injury. That is the reasons of physical trauma. Thermal injuries, the first from this group of physical trauma, thermal burns. The reasons of thermal burns. Thermal lesions of the oral cavity can be divided into high temperature burns and rarely low temperature burns. Thermal injuries to oral soft tissues most commonly occur due to accidental ingestion of hot food or beverages. The biggest culprits are hot cheese in pizza and hot coffee or tea. Microwaved food may also cause burns because the food may be hotter in the middle than on the surface. Coagulation of protein or destruction of cells can occur at the temperature of 44 degrees above zero. Clinical manifestation. Food-associated thermal injuries generally occur in the palate or the posterior buccal mucosa. Clinically, high-temperature burns in the oral cavity evolve into vesicular or ulcerative lesions that is surrounded by an hyperemic edge. They appear as a sloughy, necrotic tissue surrounded by erythema, as it is shown in this photo. Thermal burn due to hot food ingestion. Diagnosis and differential diagnosis. Anamnesis data and clinical signs are important in diagnosis. Comparative diagnosis can be done with other ulcerative necrotizing lesions. Histopathology biopsy of the lesion may be specific, especially in certain potentially fatal diseases. Treatment. Treatment is similar to the mechanical trauma injuries. That's why it has as well the same steps. First of all, it is necessary to find out the reason and eliminate the reason, or at least make it not so aggressive. After that, provide oral sanitation and or professional oral hygiene. And next step of the treatment, it is symptomatic treatment. That is similar to the treatment of ulcerative, necrotizing gingivitis or stomatitis. Low temperature burn. Burns from low temperatures are clinically configured with a necrotic lesion in the affected area with a consequent risk of infection. In fact, the lowering of the temperature induces not also the crystallization of interstitial fluids, but a vasoconstriction too, mostly capillary, which causes a hypoperfusion of the area undergone. Dry ice and liquid nitrogen used in cryotherapy can lead to the development of these lesions. In these cases, the treatment is very similar to thermogenic lesions, with particular attention to antibiotic therapy given that in addition to the infectious risk that accompanies the necrotic lesions, we must consider that the low temperatures in the injured area reduce the immune defenses. Treat a dry ice burn as you would treat frostbite or a burn from heat. A red area will heal quickly in a day or two. One can apply burn ointment and a bandage, but only if the area is dry and if there is no blisters. And actually here you have accidental ice burn of the lip in the child and the buccal mucosa, lip mucosa, excuse me, due to ice, dry ice burn. The next entity, it is electrical burns. Reasons. Oral electrical burns are relatively common and predominantly occur in young children. Such injuries often lead to disfigurement and functional disabilities. Most of the electrical injuries occur as a result of sucking or chewing of live electrical wires, extension cords, plugs, or power outlets. Hence, they most commonly occur in toddlers or preschool children. Such injuries in adults are extremely rare. Clinical manifestation of electrical burns. Electrical trauma most commonly affects lips and present as a painless, charred, yellowish area with little or no bleeding, followed by significant edema within few hours. Necrosed tissues slough and heal with scarring, leading to significant disfigurement. Diagnosis is set from anamnesis. Any special methods is not used. Pay attention to these photos of children that were injured by electrical current. Pediatric electrical burn, actually, here it is called in such way. Treatment. To decide the treatment plan, it is very important to establish the severity of the injury. Such scientist as Kank points out in his review that if the burn in the lips, vestibule, or floor of the mouth is severe, the best treatment is with the aggressive approach, employing early surgical debridement followed by mucosal resurfacing. By contrast, a milder burn with limited anatomy involvement should be treated with a conservative approach. Furthermore, symptomatic treatment can be done through the local application of aloe vera or vitamin E in the post-surgical period in order to relieve pain and irritation. We have finished with live current, electric current stimulation that is usually typical for children, such electrical burns. And we right now move to electrical stimulation, electrical injuries in adults. And we will talk about metals and their galvanic currents in oral mucosa. That's why understanding of mechanical, physical, electrical surface, biological properties of dental materials enables clinicians to determine proper use and care of dental materials. So we need to understand this statement because it is essential if it goes about adults and current stimulation of oral mucosa. Electrical properties of materials. It is generation of electrical currents through a variety of means. We talk about galvanism, corrosion, and tarnish. So galvanism, it is small electrical currents that result from opposing of dissimilar metals across dental arches. Have potential to create tooth hypersensitivity by irritating the pulp. Roughness and pitting can also occur as a result of galvanic action. Second, corrosion. It is deterioration of metal by chemical or electrochemical reaction, and it can be a result of adjacent restorations that are composed of dissimilar metals, and also may result from chemical attack of metals by components in saliva and food, and this is considered tarnish. And here you have this schematic diagram that shows that at the same oral cavity, one tooth could have gold alloy crown, another one could have aluminium alloy crown. Saliva is liquid environment that contains some electrolytes. That's why it acts actually as environment that helps uh, to provide this current stimulation by these impair uh, alloys. So mechanism of galvanism. Oral galvanism is observed in patients having metal fillings of diverse electrical potentials in teeth that are either next to each other or opposite each other. Saliva serves as a conductor through which a mild current passes between two different metals in the mouth. Thus, it creates an appropriate environment for ion exchange. This can also occur when there are metallic restorations of different metals in the upper teeth and lower teeth. These two can come in contact and the circuit is completed by the oral tissues. So, schematic representation of oral galvanism. Amalgam in one tooth, gold alloy on another tooth. Current through tooth and gingiva is transferred, and as well oral fluids play significant role in transferring this current, and due to this current can be accelerated corrosion of both of these metals in the oral cavity. So we talk about such disease, such diagnosis as oral galvanosis if it goes about electrical trauma in adults. So we talk about oral galvanosis. Etiopathogenesis of the oral galvanosis is based on the corrosion of metal structures. Many factors have influence on speed and intensity of the corrosion process in the oral cavity. First, in case when the technology of manufacturing metal structures was broken, the release of metallic inclusions into the oral fluid increases that provokes the occurrence of corrosion. Secondly, saliva is an electrolyte and its composition and its pH have a great influence on the electrochemical processes in the oral cavity. And thirdly, it is known that some general somatic diseases, periodontal pathologies, and oral mucosa cause changes in the composition of the oral fluid, and as a result, electrochemical processes develops. So, clinical manifestation of oral galvanosis. The clinical picture of galvanosis is such. Patients complains on a burning sensation of the mucous membrane of the tongue, violation of taste, sensitivity, metallic or sour taste in the mouth. During examination, the oral cavity, it is possible not to reveal pathological changes, just the presence of structures which made of dissimilar metals, and it should make dentists to think about the presence of galvanosis in this particular patient. And these photos shows clinical manifestation that and symptoms that develops due to galvanosis. And these symptoms is called burning mouth syndrome, and lichenoid contact reaction in the buccal mucosa and alveolar ridge. Lichenoid reaction due to galvanosis. Here you have the presence of metal structures in the oral cavity. Here as well, metal structures. So that is the reason of galvanosis, presence of dissimilar metals in the oral cavity. And as a result, such symptoms as burning mouth syndrome and lichenoid reactions can develop, and this is unpleasant to patient and cause some discomfort. Diagnosis of galvanosis. The main diagnostic criterion for oral galvanosis is a measurement of the magnitude of the potential difference between metal structures. The current can also be measured with the help of oral galvanic meters, which can detect the strength of the current. Treatment and prevention of oral galvanosis. There is a view that propounds that this phenomenon is self-limiting as the effect of polarization sets in. This means that the patient suffers a sharp sense of pain which eventually subsides. However, for those whom oral galvanism causes considerable discomfort, certain solutions are offered. Painting a coat of resin on the offending fillings has also been suggested as a solution to break the secret. Ultimately, for some, the only option may be removal of amalgam fillings. There are several ways to prevent galvanosis. Firstly, using electroplating in the manufacture of metal structures, and secondly, conducting a diagnostic test using a plastic crown with inserts of metal alloys from which the future prothesis will be made. Galvanosis treatment is to replace metal structures in the oral cavity with metal-free one. For example, eliminating the cause of the disease. Chemical injuries. That is the next question that is discussed on this lecture. So the third group of trauma, chemical injuries. A wide array of chemicals and drugs come into contact with oral mucosa. and some of them may cause direct mucosal trauma due to their caustic nature. Some people tend to apply certain chemicals as a remedy for their oral problems, such as application of aspirin to ease toothache. Healthcare practitioners are also responsible in applying certain chemicals in the mouth for treatment or investigating procedures. Some of such chemicals, if used inadvertently, can be potentially injurious. However, such injuries are not very common since the introduction of rubber dam in dental practice. And actually, I'm focusing at this. Rubber dam is important to prevent accidental leakage of any antiseptic solution or any medicaments in the oral mucosa, and thus this armamentarium, rubber dam or coffer dam, will prevent from chemical burning in the dental office. Reasons of chemical injuries. Oral chemical burns are traditionally caused by an acid or alkalis insult. Acids and alkalis damage oral tissues in different ways. Acids cause coagulation necrosis, leading to the formation of a scarp that limits the penetration of the substances to deeper mucosa layers. Alkalis react with tissue proteins and cause liquefactive necrosis and saponification, penetrate deeper into tissues, and have extremely poor prognosis. So pay attention to these two mechanisms of how acids and alkalis influence oral mucosa in the case of leakage. The 2005 annual report of American Association of Poison Control centers the most common reasons for exposure, and they are unintentional, 83 percentage cases, suicidal intent, 8 percentage cases, treatment errors, 9 percentage cases, unintentional non-pharmaceutical product misuse, 4 percentage cases. So this is statistical representation of reasons of the chemical burns in oral mucosa. Oral chemical burn are often caused by unintentional errors by clinicians because caustic solutions like sodium hypochlorite, 1 percentage till 5.25 percentage, are widely used in restorative and endodontic dentistry. Among all dental materials, liquids are most likely to cause chemical oral burns because they are difficult to manipulate and control. And actually here you can see the sodium hypochlorite solution, that is actually that, the most typical reason of chemical burn in dental office. And rubber dam platelet that is positioned, and this serves as a protector and preventive option of such accidental leakage of acids in the oral cavity. So mechanism of action of acids and alkalis in the oral cavity. Intraoral lesions from acids normally remain superficial without affecting the basement membrane. For this reason, it is sufficient to keep the wound irrigated to avoid the surgical debridement. Alkalis. more commonly penetrate beyond the basement membrane, leading to more severe injuries. They have a strong lytic action, and studies have reported full thickness burns in just 1 second of mucosal contact with 30% concentrated sodium hydroxide. And this is typical schematic representation. What happens if there is a accidental leakage of acids or alkalis. You can see the capillary damage, tissue edema, zone of coagulation necrosis, zone of stasis, and zone of hyperemia. And after the healing process, chronic inflammation and hypertrophic scar. Clinical manifestation. The clinical findings are vary, including edema of the lips, ulceration, a wide area of sloughing covering the underlying loss of mucosal integration, and hemorrhagic crust of the lip. The commonly reported clinical sequelae following sodium hypochlorite accident include pain, ecchymosis, swelling, chemical burns and necrosis, ulceration, neurologic damage, paresthesia and anesthesia, and at times respiratory compromise. These photos shows oral mucosal burn that was caused by topical application of 36% polycresulan solution. Polycresulan is a polymolecular organic acid and has therapeutic properties as a local hemostatic and antimicrobial agent. And this photo shows sodium hypochlorite accident and appearance of the oral mucosa after the leakage of this solution in the oral cavity on the gums. Diagnosis and differential diagnosis of chemical burns. Diagnosis is not hard. Data should be obtained from anamnesis and clinical findings. That's why it is necessary to collect complaints, anamnesis of the patient very thoroughly to set appropriate diagnosis. And when the diagnosis is set correctly, after that can be prescribed appropriate treatment. So diagnosis is of great importance. This photo shows superficial oral burn due to placement of an over-the-counter anesthetic gel. Pay attention to this area of necrosis after application of anesthetic gel. The first aid. In the case of chemical leakage, the first what the dentist, or if it happens in the dental office, should done, or if it happens at home by patients' misuse of medicaments or something else, we have these statistics. So sometimes it is inappropriate use of medicaments. Patient do not follow instructions. That's why such chemical burns occur. So the first aid, rinse and clear burn area. Rinse with great amount of water, enough amount of water to wash out all remnants of acid or alkali from the oral cavity. Flood area with cool water for at least 20 minutes or until the help arrives, or until, yes, the emergency care will come. Make sure water does not flow onto another part of the person's body or onto you as a dentist. Do not use a strong stream of water, if possible, of course, as this strong stream of water can cause damage to the burnt area. So this is the first aid of accidental leakage of chemical solutions in the oral cavity. Treatment. To resolve injuries and promote healing, an immediate course of corticosteroids associated with irrigation of the oral mucosa is recommended. Surface irrigation is often not sufficient, so surgical debridement becomes necessary. Systemic therapy with antibiotics and antifungals are administered to avoid the development of infectious complications. The final issue to discuss is radiation-induced stomatitis. It is an inflammatory response of the oral mucosa to the use of anti-neoplastic drugs or ionizing radiation that are used in treating head and neck cancer. It is a normal tissue injury that is caused by radiation or radiotherapy, which has marked adverse effects on patient quality of life and cancer therapy continuity. It is a challenge for radiation oncologists since it leads to cancer therapy interruption, poor local tumor control, and changes in dose fractionation. Radiation-induced oral mucositis, it is another name of this disease, occurs in 100 patients of altered fractionation radiotherapy head and neck cancer patients. The reason of radiation-induced stomatitis or mucositis. It is ionizing radiation causes damage to normal tissues located in the field of radiation. Oral mucositis may result from irradiation that induces the death of the basal cells of the mucosal epithelium, usually 2 weeks after the beginning of radiotherapy. Many risk factors have been identified for radiation-induced oral mucositis. These risk factors include concomitant chemotherapy, bad oral hygiene, below average nutritional status, lack of antibiotic use at early stage mucositis, and smoking. Radiation-induced oral mucositis is a major dose-limiting toxicity in head and neck cancer patients. Such clinical manifestations is observed. Radiation-induced stomatitis is characterized by xerostomia, dry mouth, due to lack of saliva. As salivary glands, it is such organs that is the target for this radiation, and they are the first who react to the radiation stimulation. That's why xerostomia is typical manifestation of this radiation therapy. Diffuse erythema, ulceration, taste alteration, oral soreness, dysphagia, difficulty talking, and mouth odor. These are the main symptoms of radiation-induced stomatitis. Usually it starts asymptomatic. Later on, an erythema appears and it may be followed by erosion or ulceration of the oral mucosa. The ulcerations may be typically covered by a white fibrinous pseudomembrane coating, Discomfort or severe oral pain may be caused by oral mucositis, as well as difficulties on drinking, eating, swallowing, and speaking, which impair patients' quality of life. Pay attention to this photo of oral radiation mucositis. On the hard palate, on the lateral border of the tongue. Treatment of such disorder. Attention to the mouth hygiene, particularly using mouthwash, has a fundamental importance for these patients. Among the mouthwashes, the ones containing normal saline, ice pieces, honey, allopurinol, benzidamine, chlorhexidine, chamomile, and glutamine are worthy of mentioning. Non-chemical mouthwashes of honey and chamomile are of these mouthwashes. And of course, laser phototherapy can be suggested as a treatment for radiotherapy-induced oral mucositis. And this photo shows one of the stages of the treatment after using of laser phototherapy to the patient. Of course, it is not healed oral mucosa, but it is one of the stages of laser phototherapy. In conclusion, such statements was drawn. First of all, trauma-related oral lesions are common in clinical practice of dentistry, and they can impair patients' normal oral function and cause pain in patients eating, chewing, and talking. An injury to the oral mucosa can result from physical, chemical, or thermal trauma. Such injuries can result from accidental tooth bite, hard food, sharp edges of the teeth, hot food, or excessive tooth brushing. Some injuries can also be caused by iatrogenic damage during dental treatment or other procedures related to oral cavity. Similarly, chemical or physical injury could result from undue or careless handling of chemicals and dental instruments during dental treatment procedures. So it is important to be aware of common causes of traumatic injuries, their diagnosis, and management. References and suggested further reading. Chemical, thermal, and electrical lesions in the oral cavity. It is available from this link. Managing sodium hypochlorite accidents, the reality of toxicity, available under this link. Oral mucosal burn caused by topical application of 36% polycrystalline solution, a case, available under this link. Honey and radiation-induced stomatitis in patients with head and neck cancer, under this link is available. Radiation-induced oral mucositis, Frontiers Oncology, available on this link. Thank you for attention and have a good day.